Good
Get
evening,
Dr.
everyone.
Miller's video on.
Welcome to another evening of education, sponsored by Refuah Health Center in collaboration with the Mount Sinai Medical Center. I want to once again thank our esteemed panel of distinguished physicians who are known to the community, physicians who have treated generations of our community, who have taken of their time to come tonight and help us understand a little bit more about this disease that we've been facing for so many months. Without much more ado, I want to hand the mic over to Dr. Jeffrey Bander, and Dr. Bander will take it from here. Thanks so much, everyone, for joining.
Yeah, so thank you. So this is really meant to be a conversation amongst the community. And, there's lots of formats where people get information from on the internet and the news, but this is really meant to try to drive how it affects our community. And unfortunately, right now, we're in a mode where, we are in the hot seat, both, from what's going on in terms of our patients being affected, but in terms of us as a community, how we're responding. And so this is meant more on the clinical side. And so we have people on this panel who's well known to the community, who've taken care of a lot of our patients for many years. Dr. Miller keeps popping in and out, but first I want to introduce Dr. Miller, who is my Rebbe, trained me in cardiology. So he's a cardiologist at Mount Sinai and an expert in the field of coagulation. We have also Dr. Larry DiFabrizio, whose name now, if you have a patient at Mount Sinai, he's been seeing the vast majority of the patients. So he has a good insight into what's going on, as well as a long-term relationship with the community. We also have, is Dr. Hammer on? Not sure if he's able to get on yet, but we have Dr. Schatzkis on as well, who's another cardiologist, frontline COVID provider who's been following most of the cases, also an expert in anticoagulation and COVID therapies. And we also have this time David Lubell, who is an OBGYN at Mount Sinai, also familiar with the community's needs, as well as delivering patients during COVID and answers questions about newborns as well as pregnancies. So I think we're waiting for Dr. Hammer to join from infectious disease, also well known. We're going to go through several topics tonight, try to cover, catch up to where we've been in terms of the last few weeks since Rosh Hashanah, in terms of the infection rates, how we've been treating patients, and kind of go through several topics related to COVID. So if you have questions, there is a way to do chat us the questions, and we'll be asking the questions as we go through the different panels, different sections. So we're going to start tonight with some updates, and we'd love to hear from Larry and Josh first, who've been in the hospital, as to what we're seeing now about the virus. Is this different now than we thought 2 weeks ago in terms of how sick the patients are?
Well, I would think, and thank you firstly for having me join this great panel, and I look forward to a good discussion tonight. We're seeing a bigger spectrum of illness. I think, many months ago, when this thing started, we were telling patients not to come to the hospital unless they were deadly ill. And frankly, what we found was that 25% of the patients that were tested actually required admission, and we had a very substantial in-hospital mortality. At this point, we are, admitting a wide variety of patients in terms of the acuity, how sick they are, and they're doing much, much better. I mean, from my own personal experience, we've not yet had one mortality among probably 100 people that have been admitted over the last couple of weeks. So there's a lot of things that are positive that are going on, but there has been a change. And I think particularly because we are getting to people earlier, and that we do have a significant program to provide for patients, which, as we are going to discuss in more detail, has included, plasma antibodies, steroids, anticoagulants, and an antiviral medicine, remdesivir. And so even in patients who have required ICU care, who have been intubated, we've actually had no mortalities in that group, where in the Northwell experience very early on, there was up to an 80% mortality. As people got to know better what to do, it came down to like 40%. But so far, we're doing well, and people are getting critically ill. This is not a joke, but so far, we've not had people die. We have had people get extremely ill.
Josh, in your opinion, what's different this time? What do you feel is?
Can you hear me?
Yep.
I think the biggest difference, as Dr. DiFabrizio just expressed, is that we have a very clear plan when patients come in. And so I think that we are, quote unquote, cutting off at the pass the severe illness that was killing so many people before, because we have a better idea of how to treat them up front. At the same time, I'm not convinced or clear that this is in some way different illness, because we're still seeing some of the similar inflammatory reactions in these patients. I think it's more about what we're doing than about the illness itself, because the patients are coming to the hospital and we're just doing a better job up front.
Yeah, no, I would agree. I think 2 weeks ago we sat here on a similar call with a different panel, and the volume was certainly not as great. We were worried about this breaking out. And I do agree that it's the organization and getting people the therapies. Dr. Meller, I mean, in the first phase of pandemic, steroids came into use at the end. What's been your opinion? It's both being used at home and in the hospital on the efficacy of this.
You can hear me?
Yes.
You hear me? Okay, good. So far, I have the majority of my patients are still home. They are not getting into the hospital. I have only, at this point, a couple of patients only in Mount Sinai with COVID. And at home, if they are really having just a fever and a cough and they're feeling well, I usually am doing nothing. You understand me? So we just wait for them a little bit at home if they are not feeling very sick. The people are still very afraid of coming to the hospital, but as you know, it's much safer now to come to the hospital and be treated appropriately, let's say. The biggest problem is patients are not happy that they cannot be visited by, they cannot have visit by the relatives, obviously. So at home, I have not used steroids. If I think they will need steroids, and that would be that I'm getting blood tests that show marked inflammatory markers, I think that at that point, I would put them in the hospital. I'll feel more relaxed, even if the oxygen is running very well. We also have learned when to anticoagulate, and some patients get anticoagulated a little early, by the way, even at home with the oral anticoagulants. And for that, we get a blood test. If the D-dimer is over 1.5, we really at that point start anticoagulants at home, especially when I'm talking with people who have where the O2, and I am telling every patient actually to get the oxygen meter in the finger, or if not, to call Hatzalah and just have it checked. And if it goes down to 94 below, that's the time to start checking for that. If it's lower than that, they belong in a hospital, really.
So I really want to gonna dig into that in a few minutes, because I think one of the core topics for tonight will be treating patients at home as we have more and more, and who needs to go to the hospital. And I think last time we really made a clear message that if your SAT was less than 94%, those patients would benefit from an evaluation hospital for plasma and remdesivir. So before we go on to the home, I just want to stay on with the doctors who are, rounding in the hospital, which would be right now Larry and Dr. DiFabrizio and Dr. Schatzkis. We are giving patients, if they come in less than 94%, they're being screened for plasma and remdesivir. I think what makes the biggest difference right now in terms of treatment is the fact that when we didn't have a high volume of patients, it was pretty easy to manage it. And as we scale up, as we see the number of positives have increased significantly from Rosh Hashanah and then to Yom Kippur, and now on Sukkot, seeing that the number of patients, the census has gone up to about 40, 45, and about 85% now there's been an outbreak in other communities have been from our community in Mount Sinai Hospital. In Mount Sinai, Queens is a different population of patients. But the fact that we have these treatments early on, we were easily organized. So like you, a lot of us get phone calls at home on these patients. So Larry, are you treating patients at home? I'd like to just hear what everyone's criteria and their thresholds are for keeping patients at home.
So I have some patients, and families, you know, father, sons, cousins that are home. And in general, if they have low-grade fever, dry cough, but, you know, not escalating fever, I think the hallmarks of serious illness are, you know, shortness of breath, moving around the house. So if you're, and one of the peculiarities of this condition is that this kind of pneumonia may cause low blood oxygen, but if you're not moving around, you may not actually be that breathless. So the oximeter is actually a very helpful tool here. And I don't recommend people, you know, using oxygen at home at 2 and 4 and 6 liters, because that puts you at great danger. So I think if you're having escalating fever, so if you have a 101, 102 fever and you take some Tylenol, the next day or two you start feeling better, that's fine. You know, you may have a dry cough, you may have a little phlegm, there may be some cough with a trace of blood, but if you're not getting progressively short of breath, it's okay to stay home. If you're getting more and more breathless with activity, you must be evaluated, because we found that those patients that are breathless usually have quite low blood oxygen. And the pulse oximeter is a very helpful tool because it also gives your heart rate. If your heart rate's running over 120, 110, and your oxygen is below 95, you should get at least a phone call to a doctor. And once you get below 90, you must absolutely be in the hospital. I think we've seen bad outcomes in patients who got oxygen at home and didn't get the treatments that we could provide, because, you know, you can get behind the 8 ball pretty quickly with this illness.
So, Dr. Miller, what do you say? Because there are been different opinions, and it's good. Kind of, this is a different panel than last time. We don't have, we can talk a little bit more about this. So, Dr. Miller, what's your threshold for coming in?
You can call me Jose too, also.
I can, yeah, not on the panel.
No, I know. I'm just. I would say this. I have patients, by the way, and we disagree sometimes among ourselves on how to approach. And as you know, there are some patients in Borough Park who will definitively not come to the hospital if they can avoid it. And we have some patients who are oxygen, just nasal, 2 liters, and they started with an oxygen of 92, and then now they're running 96, 98. And I tell them, if they're not having a high fever, fine. I agree. As soon as the oxygen goes below 90, they belong to the hospital. Even in the 2 liters, if they start going down or they remain in the lower side, I tell them to go to the hospital. And I agree with the fever. When it starts reaching 103, they have to be in the hospital, because that's a significant illness at that point. But if it goes down to 92, and I'm curious about if Larry, Dr. Fabrizio would agree, if they want to stay home, I myself put them on an oral anticoagulant. I'm not sure if he would or not.
Well, I would. It's interesting. So if people are just not going to come in and they're hypoxemic, I do think that being on an anticoagulant and possibly on some steroids makes sense. You know, there is good evidence that people with hypoxic respiratory failure, dexamethasone is helpful. I know that there, you know, we've had a whole go around about Plaquenil. In my own personal experience, I think people felt better on it. There's no proof that it actually changes significant outcomes, but the Plaquenil has, for many years, had anti-inflammatory properties. So, you know, getting the fever down with medicines like Tylenol, and, you know, and if they have low blood oxygen and the patient just committed to not coming in, you know, I certainly would agree with being on a blood thinner as well as on some dose of steroid. The only steroid that has been, at least in a randomized trial, shown to be helpful is dexamethasone. And we are using that or some other form of steroids when patients are hospitalized. So, but again, that's not my current recommendation or practice, but I think for some individuals who just will not come in, you know, I would be afraid to let them be on no treatment.
So let's review. Dr. Schatzkis, do you have an opinion on this as well?
I do. So mine is bit of a variation on what both Dr. Meller and Dr. DiFabrizio have said. I agree with Dr. DiFabrizio's initial strategy, which is the patient has to be able to judge their breathing. If they are really feeling like they're starting to have shortness of breath, that's already a red flag for me, period, stop. There are plenty of patients where I'm seeing patients in the outpatient setting. I'm in Borough Park, I'm in Williamsburg, where patients are coming back positive. And even if they have mild symptoms, I am checking those patients with a test called a D-dimer. If those patients are coming back with a high D-dimer, even if I'm not sending them into the hospital because they don't have sufficient symptoms to warrant hospitalization, but if their D-dimer is elevated, I am putting those patients on what we're calling low dose of anticoagulation. It's not a treatment dose, but it is a low dose. I would say this overall, and I don't think this is a rule, but what I've noticed overall with the patients that we have at Sinai, most of them that have been admitted have been into their second week when things really, really progress. They're usually coming to us somewhere between day 7 and day 11 when things have escalated enough. So you're not going to really know in that first week when you're sick if you're going to be one of those patients who's going to have sort of a downhill course. And so I think it's really important to stay in touch with your doctor, and patients should be watching their symptoms if they're finding that they're getting worse gradually as things go along. And my overall strategy has been to monitor my patients and follow them once they start telling me they're not feeling well, keep in touch with them and make decisions going forward based on their symptoms after that.
Dr. Lubell, anything pregnant women, are they at higher risk, lower risk? What's your threshold for having them come in?
So the CDC recently revised its recommendations back in June of 2020. And the data suggests that pregnancy is a risk factor compared to non-pregnant women the same age. Pregnancy alone can increase the risk for severe disease. The numbers actually show that there was a higher rate of hospitalizations, ICU admissions, and intubations. So that risk is there. We do have a lower threshold, especially if pregnant women are experiencing respiratory symptoms. The women's respiratory physiology it's overcompensated, and we can't really use the values that we would use for non-pregnant women. So generally speaking, if someone's satting below 95%, that's something that we'd be concerned about, and those patients do need admission. Also, there can be a rapid deterioration just because of the dampened immune system that we see in pregnancy. Also, pregnancy is a hypercoagulable state in and of itself, so thromboembolism is also a risk. So pregnant women are different than non-pregnant women. We would have a lower threshold to treat, especially if they're having respiratory symptoms, and they need to be monitored carefully.
So are we seeing a lot? I mean, we're not on our end seeing a ton of pregnant women in the hospital. Is that something we learned from outside communities?
Well, it turns out that the majority of COVID-infected pregnant women will do very well. Both they will do well and the infants will do well. In fact, the majority of COVID infections are completely asymptomatic. There are, however, a small subset that can do poorly, and we did see that with the first wave, not with this second wave so far. But we did see patients, especially some in our community, that were admitted to the ICU, required intubation, and also required earlier delivery, and most of those deliveries were by cesarean section. And the data actually supports that women who are pregnant, who are symptomatic, are more likely to have preterm deliveries and are more likely to be delivered by cesarean section. So it's just something to note that pregnancy is a risk factor, and these individuals need to be watched a little more carefully than their non-pregnant counterparts.
And so what do you recommend a pregnant woman who's home? How do they monitor themselves?
So it really comes down to respiratory status. So if a pregnant woman starts to complain of shortness of breath, lightheadedness, dizziness, again, just with minimal exertion, if she's not feeling up to it, that's already a warning sign. There's an increase in oxygen demand in pregnancy. So even mild exertion with some respiratory decompensation could be pretty obvious. So these are women that if they start having respiratory symptoms, that's our cutoff. Also, we do encourage them to have their oxygen saturations checked. And if they do drop below, I would say 96%, it does start to become concerning.
That's interesting. I mean, most pregnant women, especially in the later, even second, third trimesters, are often have shortness of breath. So it must be difficult to discern this.
Right. So a lot of these things, a lot of these symptoms will overlap, and that makes it, it kind of muddies the waters a little bit. I mean, fatigue is a common complaint, lightheadedness, dizziness, headaches. You also have other comorbidities that kind of overlap with COVID, including preeclampsia and HELLP syndrome. So it's important to differentiate the two, and I think that's where COVID testing comes in. If anybody needs to be universally tested, it's pregnant women, and they are on admission to Mount Sinai for obvious reasons in terms of prevention. But we're also starting to implement that in the office as well, because it's important for us to know the difference if someone is having symptoms and if it is related to COVID.
Yeah, it's fascinating. I'd say I agree with you that the majority, we see a ton of COVID positive women delivering at Sinai, and they're all asymptomatic or just we just say that they have an asymptomatic positive test. So it's interesting. I just want to go back because it's going to affect so we're back on that question of who's coming into the hospital. And I think there's what we say we should do. And on the last call, we had hospital leadership on, there are plenty of people. We all know there are plenty of people at home on oxygen concentrators. There are plenty of people at home even on high dose oxygen, on BiPAP and other forms of oxygen. So, we say here, we do know that this is happening. People are admitted are at home being treated. So if we go back to what we said of Dr. Miller, Dr. DiFabrizio, we really don't have a good cutoff. But I think what's important is what Dr. Shotsky said, was that the people who are coming into the hospital, when you come in day 12, day 13, day 14, you've already been treated. You've already missed that window for the best benefit for remdesivir and plasma. So it's really hard. So just going back to the same people, go back to starting with Dr. Miller, Dr. DiFabrizio, then Dr. Shotsky. If we don't know who's going to get sick, day 12, day 13, we can't have everybody come in, who's got a fever of 101, 102. It's going to overwhelm the system. So who do you recommend if they were going to come in early? Which patients are you going to say to come in early and when they're diagnosed in the first 7 days?
Well, I would say that those that have significant comorbidities up front. So if you're age over 75, you've had diabetes, which is unstable, hypertension, coronary artery disease, you have COPD as a baseline, and you are even an active smoker, kidney failure patient, somebody on dialysis, you're going to be at an extraordinarily much higher risk. So that would be somebody that I'd want to know about early. And, I think also assessment of oxygen, because many patients are not that active. And this disease is very striking in that in some instances, patients can have profoundly low blood oxygen and not really complain of that much shortness of breath. And so that happy hypoxia is a harbinger of bad outcome also. So I would say, if you're 22 years old and you're pretty healthy, well, then you're generally going to be a low risk population. What we saw initially was that 8% of the patients who developed COVID were over the age of 75, but they made up 50% of the mortalities. And between 65 and 75, that made up the next 25%. So 75% of people would be considered seniors. So I think if you have an older patient, again, with diabetes, hypertension, coronary disease, some chronic kidney disease, or some significant chronic lung disease, that would be somebody that, I would just pay extra attention to.
So Dr. Miller, do you agree? Are you sending in 50-year-olds with diabetes, don't have O2 sats?
No, I have not. And I have not lost patients in the outside, so I don't. But I usually wait, and if they are really relatively stable, and I follow the same as Larry said. Actually, if the oxygen starts going down, I send them to the hospital. If the fever persists, really goes to the level of above 1.2 or 102, 0.5 or 102, I tell them to go. If they're feeling sick, I send them. Shortness of breath is a good marker, but some people are short of breath with an oxygen of 96, 98, And at that point, I asked them if they have been short of breath before, and they tell me, yeah, once in a while I get short of breath, and then you get stuck. But I'm talking, if the patient is even diabetic, I don't send them to the hospital just because of that risk factor, let's say.
Right.
However, I know that that's a risk factor. The obesity is a risk factor. We would overwhelm the hospital if I sent all of those.
Right, and I think that's correct. So who would you send early right now before they get hypoxic?
I would send somebody who really has a very high fever, somebody is having continuous diarrheas, because I have those patients who develop severe diarrheas as another manifestation of the COVID. Patients who feel sick, really, if they feel really sick, and I try to get blood tests, you can get them in the same day. If they're really, the inflammatory markers are quite high, the D-dimer is elevated, I tell them to go to the hospital, or if other things are going on at the same time. By the way, when I talk to the people, I talk to infectious diseases in Italy, who they started earlier. We actually were 1 month following them. They don't use steroids like we use them here. They wait for a patient to have severe inflammatory markers before they start using them. They don't start them so early. And when I talk to them about plasma, because I said we have been using plasma in everybody because we think it helps, they tell me, well, you have no proof that it works. There is no study that tells us it works. We have a sense that it works, but they are very much more conservative in that sense than what we are here. With the anticoagulants, they were the first one to describe the clots. So they are enormously aggressive with it. They said, listen, almost every patient, we may be starting late, and they don't use the half-dose anticoagulants. If somebody has a D-dimer of 1.5 or over, they go on full dose anticoagulation because of what they saw in their patients, really.
Right, and I think that's helpful. I would say that just sticking on the theme here of when to come in, we'll come back again. I'd like to really circle back on the plasma steroid anticoagulant use in a second. But Dr. Schatzkes, would you send anyone into hospital before they were hypoxic?
Yeah, I'm trying to maintain an open dialogue with my patients. Once I find out that they're positive, as you know, Dr. Bander, I'm caring for a lot of the communities that have a big spike right now. And so I've been having a lot of these conversations, and it's really a case-by-case basis. I take into account their risk factors and longitudinal conversations, trying to decide when the right time. It really comes down to similar things mentioned by the other physicians on this call, which is, do you feel like you're getting worse? How is your breathing? Are you eating and drinking okay? If I'm talking to a family member, does the patient look like they're getting worse? There is no hard and fast rule, but if I get a sense from the patient or a family member that they feel like they're turning downward, I'd rather them go to the hospital than not. I think that's an important point for all the listeners, is that at the moment, the ER is not overwhelmed. We are, of course, worried about the system getting overwhelmed, but at the moment, we are not overwhelmed. And certainly if you're not feeling right, if you think that things are not going in the right direction, I'd rather that patient be evaluated than not be evaluated, whether it's in the office with me, if it's during regular hours, or if I'm unable to see that patient in the office, I would be more inclined to send them to the emergency room at that point.
Okay, so we agree, and I think, again, it's that balance, right? We get back to that balance, is that the vast majority of people who have COVID, even with risk factors, will recover at home, won't require. It's that, that top percentile group that gets very, very sick. And the problem is once they come in too late, we're playing catch up. So I think that, from taking everyone's on the call, my own recommendations are, if you do have a lot of risk factors and you already are at that 94% mark, just come in, because if your plasma is going to help you, remdesivir is going to help you, it's going to be early. And I disagree with Dr. Meller on the data. We do have some pretty good data. We don't have a randomized control trial on plasma. There's definitely been some of our data, at least our matched control trials that we did, that Mayo did, that shows it's beneficial. And I think that most of us who are seeing patients see a benefit. Now, what's going to be difficult to tease out is going to be which of the 4 treatments that we give patients are really the ones that do it. I think that I want to do another lightning round on that in a minute, whether you think it's the plasma, remdesivir, steroids, or anticoagulants. But I think that, we're pouring all 4 treatments into people at this point. And I think for this segment, we're talking about when to come into the hospital. Early is better if you're hypoxic. And I think a good key point Dr. DiFabrizio and Dr. Meller made was this sort of move around a little bit and see if you get hypoxic. I think that's a good way for differentiate. So if you have risk factors, you're diabetic, you have heart disease, and you're short of breath walking around, check a O2 sat walking around. If it's 90, could just come in. I think if I put everyone together, that would sort of be a meld of where we're at. Now, just going back now to second in the hospital, right? So Dr. Meller, if we don't believe in plasma and remdesivir, and you're really not giving steroids till late, what are you getting in the hospital? Why be in the hospital?
No. By the way, I give all those therapies because we have seen from the beginning, as soon as we had plasma available, we started giving it, and we had a sense that those patients were doing better, and I have seen the studies. But you remember, Dr. Fuster has been talking, we are waiting for the big study to really be definitive, but all of us, we had a sense that the patients getting plasma were doing better. And the antiviral. With the steroids, we have a sense that we may, you remember, the ones who had significant inflammatory markers, they did better. We waited for those. I don't give them at the beginning. I would not give steroids at the beginning. Let's say somebody who comes and who gets hospitalized, let's say, comes because the fever is 102.5, and has the oxygen went down to 90, and it's already improved immediately with a small amount of oxygen, and I put them on anticoagulants. I will give them antivirals. I would give them the plasma, but I would wait with the steroids unless the inflammatory markers are markedly elevated, which very often are, by the way. So at the end, I think we all end up treating the patients the same way. I may have in my mind one type of a patient, you may have another one, but I think when we see them, we all tend to do probably more or less the same.
All right, Dr. DiFabrizio?
Yeah, I would say it's been our practice, and so everybody sees the kinds of patients you get called for. And because I'm a pulmonary specialist, I see people who have significant shortness of breath and low blood oxygen. So if I'm getting called in on these cases, most often the patients are more significantly ill, and I'm not seeing the milder cases. So it's been our practice to provide some form of steroid for people with hypoxia. And so the only data really exists, and I agree with Dr. Meller, if you're not hypoxic, there's no benefit, and there is a possibility of harm. And so particularly if you're diabetic, the steroids were not recommended by the WHO in the beginning in the CDC because of the fear of actually prolonging the viral production and exacerbating that. But because we have remdesivir, which has some antiviral activity, and we're using combinations of therapies to block the virus, to absorb it with the plasma, to stop it with the antiviral medicine, and then we can provide the steroids if they have profound hypoxia. Generally speaking, the patients who have very low blood oxygen have a more advanced form of COVID. So, they the steroids and hypoxia story go hand in hand. And I think, that's one of the main points of view, and in addition to the blood thinners, which I think is really key. When we were in the intensive care unit with these patients, they were thrombosing everything. Every time we put a dialysis catheter in for the most sick patients, they were clotting. So I think it's going to be very hard, as Dr. Bander said, to tease out what is actually most important. What we do see is that at the days 5 to 10, which have been pointed out after the illness begins, is when we're starting to see those poor people who develop what's called the cytokine storm. And that's where the anti-inflammatory therapies work. In some instances, the patients who are late may actually have a low viral load by that time. And, antiviral medications and the plasma may not be beneficial anymore.
So treating early is key, but we don't know who to treat because most people get better. We're back to that same question.
Right.
So what is your, Larry, what is your threshold for starting steroids? What makes you start steroids? Is it the hypoxia?
Yes, I think, it's probably looking at the patient's work of breathing, how high their temperature is, getting their systemic inflammatory response under control is very important. And I think, frankly, that may have been why some patients actually felt better with Plaquenil. Plaquenil is a long-term, it's been a very old medicine. It's been around forever, and it acted as an anti-inflammatory. So maybe if we would have given people 10 milligrams of prednisone when they were home, they might have felt better. If they just got Tylenol, we told people not to take anti-inflammatories. And, theoretically, sometimes, NSAIDs can be prothrombotic, and so, we avoided those. But, getting their fevers under control is important. And it does probably provide a degree of symptomatic improvement and does curtail this inflammatory response syndrome.
So what stage do we start the steroids, I guess is the question. If you're still in the infectious stage, as said
Well,
Dr. Mallard, would you?
I think that we're stuck, because if they're hospitalized and they're hypoxic, we're giving it. I mean, that's kind of been our protocol. If you're hospitalized and you have only a mild disease, you may be a candidate for plasma or some investigational monoclonal antibody, and then you can go home. We just like to make sure that you're okay before you leave. So there are patients who are coming in, don't need oxygen, don't need steroids, and, may actually need some fluids. And Dr. Mell is absolutely right. Some of the patients are breathless because they're so volume depleted. They have barely any or no pneumonia, but, that profound dehydration causes tremendous weakness.
Jeff, can I ask you a question? You I don't know if you're in charge of 10 West or not, but is there any patient there who is not getting the 4 therapies there?
Yes.
Yes. No, there are patients who've been admitted to the hospital, probably, a quarter of them that are not are not getting, the whole cocktail. And, they're being admitted because they have a high fever, they felt badly, and they're being observed. And, Jeff is actually seeing almost all of those. We are not seeing patients who are out in less than 2 liters of oxygen, unless we're specifically asked to see those patients. But there are patients in the hospital who have milder disease, and some of which, could go home after a day of plasma.
Yeah. I think that, the vast majority of people who are on oxygen qualify. We give all 4 therapies to, or we push for it. People who have some liver dysfunction or renal dysfunction may not qualify for remdesivir. And even the diabetics, we're pushing high dose steroids, and we're just covering them with insulin. We think that, to me at least, that's the benefit. And anticoagulants, I think, Josh, I'll let Josh speak on that. I think we've been pretty aggressive. Josh?
Yeah, and before I address the anticoagulants, a quick point about steroids. I was on the first wave. I was in that first couple of weeks, and in the first week that we were caring for patients, we were specifically avoiding steroids. And I found that when we started employing steroids a few days into the first wave, I found that was a big change for our patients. So I do think there's a major role for steroids. When the right time to start it is, I'm not completely sure. I can say I'm a little more aggressive in starting it, especially if I get patients back with abnormal labs. Even if I'm not sending them to the hospital, I may consider starting them as an outpatient if it's a patient that I'm worried about turning the wrong direction, but they're not quite either ready to go to the hospital clinically, or they personally are not interested in going to the hospital. Regarding anticoagulation, I think that was a major turning point for us overall. I still remember during the first wave hearing stories, not only from our own hospital, from my brother who works in New Jersey, and from other colleagues in other hospitals, about autopsies being done and patients being found to have clots all over their bodies from this virus. And I don't think we yet know exactly why that's happening. I think that's been a big game changer for us in preventing some of the sudden deaths that occurred during the first wave. And so I am fairly aggressive with it, as I said before, in the outpatient setting, starting patients on the lower dose if they have even just a positive D-dimer. And if I have any sort of concern about them, or with regards to clots in their lungs, some outpatient places are not doing COVID patients. They're refusing to do still COVID patient imaging. Those patients I might even start on therapeutic dose as an outpatient, because I'm that concerned about that patient if their D-dimer is really high. In the hospital, we're being fairly aggressive with it as well. It's part of the standard protocol up front. And we leave ourselves room to increase from a moderate dose to a higher dose if needed. If somebody's D-dimer, again, is, I think, a very essential test for us, even though we're not sure exactly how it's working and why some patients are really high and some patients are only mildly high. It does give us some level of barometer that we don't really understand yet in telling us about who the really sick patients are. And we're using that to help guide our therapy.
Well,
and hopefully we can find more of that going forward.
Let's just get back to the panel. But David, do pregnant women get any of these treatments, or do we avoid it?
Yeah, so all these treatments that we discussed have been used in pregnant women, mostly in case reports. None of the clinical trials, I think, include pregnant women. But the use of remdesivir, plasma, definitely dexamethasone, all these treatments have been used in the severely acute patient.
Okay.
The data, we just don't have as much data, but case reports have there's a bunch of case reports on it.
I just want to remind that the audience can ask questions on YouTube. There's a click on the YouTube logo. You can ask your questions. I just want to go through some of the questions that were asked, and ask Mrs. Sternberg to remind me. There was a question about CRP cutoff. Is there a CRP magic number, Dr. Meller, that makes you start treatment?
The truth is not magic number. It has to be, usually gets to be markedly elevated, like some of our patients. One second, let me just. Some of the patients, you see it's written 35 because they don't check it even above 35. Once it's more than triple the normal, to me, that's already significant.
Would you start them on steroids at home, or would you send them in?
The truth is, as you heard, I am very scared of starting steroids at home because if it could have a detrimental effect. So at that point, when I am deciding about steroids, I am already ready to send the patient to the hospital. You understand me? At that point, I want them to get everything. I want them to get the antiviral when they're getting the steroids. And at that point, I said, listen, get the fresh frozen, get the plasma, convalescent plasma, and obviously they are on anticoagulants.
So for you, if the CRP is triple digits, that's the kind of warning sign to you to come in. Dr. DiFabrizio, what would you do? Would you send them all in, or would you treat them at home?
Well, it's interesting. I don't really rely on the CRP test so much as their clinical findings, but it does go hand in hand with people who are sicker. And, and I agree with our other panelists that, I'm more concerned about an elevated D-dimer than I am the CRP. So I don't think I would just treat a CRP. I would only treat it in the context of whether they have hypoxia or other organ damage. So if they're, and quite honestly, more that I think about this, weakness and profound, inability to move around and lightheadedness, those kinds of symptoms, in addition to the shortness of breath and the severity of the cough, are more meaningful to me than a CRP value.
Now I'm in Zoom.
Good. So what about asthmatics? We have a lot of asthmatics in the community. Is there anything precautions?
Well, what's interesting is that asthma is a mild risk factor. We've been very, very fortunate that if you have very, very severe asthma, that's problematic. But it's important for both the pregnant women and for anybody else, if you have asthma, that you have to continue your asthma medications. The fear of the inhaled steroids is not really appropriate. But in the New York State Health Department website, they list the top 10 risk factors for bad outcome, and asthma is not even on the top of it, the top 10. So people assumed that asthma was going to be a big problem. It frankly is not so much. Many patients who were short of breath were given asthma pumps for COVID, and those pumps didn't really help that much. But if you have underlying asthma, it's important to maintain your control of medications.
There's a question also that came in about what we're seeing with patients in the hospital with plasma. I'll answer that, and then I'll ask Dr. Schutz's comment. When we see patients come in the first days, 7 days, and they get plasma and remdesivir and steroids, within 24 hours, we usually see in 80% of the patients a good turnaround time and a faster discharge. Once they get it, say people said when that viral load's already low, the plasma and remdesivir doesn't have as much effect. So we see the earlier patients have the most benefit. Anyone else, Josh?
I agree with everything you just said. Is earlier is better. I think it's also important for the audience to understand that although you and I have both seen anecdotally that these things seem to work, that they need to understand there's also a patience needed in the days to come. There's going to be hopefully improvement, but it doesn't mean automatically everything just disappears. I think the audience needs to understand that these things help, but it still takes time. And it's probably fighting that, when they've entered that period of the cytokine storm and this major inflammatory reaction, we're fighting that off, I think, during that time. And it may take days, if not longer, for them to really come all the way back. And so we're hoping that that's what those therapies are doing.
So with, staying with the outpatient side, so we're sort of kind of unclear. I mean, I know that I'm treating a lot of patients at home with Decadron, definitely putting anyone who has a positive D-dimer, and I agree with what Dr. Mello says that the Italian data, anybody with a positive D-dimer, in my opinion, unless they're high risk, goes on anticoagulants. What's your threshold for anticoagulants, Josh?
Well, for me, if they have in the outpatient setting, if they're coming with just mild symptoms, they're not short of breath because I'm not sending them to the hospital. I'm checking a D-dimer on everybody. If their D-dimer comes back negative, I have not just unilaterally been throwing anticoagulation at all patients in the outpatient setting. I've been letting the
D-dimer positive is your baseline.
That's for me.
Larry, are you starting anticoagulants on everyone?
I think I agree. If you have a positive D-dimer, they're getting treated. I have a very low threshold for it, but I'm not treating everybody.
Okay.
If you don't have a positive D-dimer, I'm not putting them on anticoagulant.
I keep getting questions here about hydroxychloroquine. So let's again, very political topic, and everyone's still on it. So what's your thoughts?
So it's the CDC and has told us not to use it at all. So, there's been a whole discussion about the harms of it. There isn't any proof that it's helpful. Anecdotally, I think some people did feel better when they got it. Early on we gave every.
So would you prescribe it?
I think right now I am definitely not prescribing it anymore.
Dr. Meller?
No.
Nobody. Dr. Schatzkes?
I have not been prescribing it, but I will say that some of my colleagues still are, and those were predominantly physicians or practitioners who were only in the outpatient setting during the first wave and are fully convinced that they kept their patients out of the hospital with hydroxychloroquine. At the same time, I was not one of those physicians, and I agree with Dr. DiFabrizio and Dr. Meller. I do think that there's probably a political aspect that's influenced the way that medication is going to be used going forward, though.
Yeah, and I don't disagree that it may have had a positive effect in symptomatic control of patients. So, that hasn't been looked at. There is one study from the Midwest that showed that it was helpful, but I do agree that the whole thing had been politicized. And unfortunately, it is very, very difficult to do randomized trials in the United States on patients for drugs that are not, proprietary, meaning that, in a drug that is promoted by a company that is, on patent, the companies will provide resources and infrastructure to study the drug. But, there is it's a real challenge to study drugs that are off-label, that are generic now, and it can take several weeks to months to get something through the IRB, which is the Investigational Review Board of the hospital. So it's actually very challenging to study a medication like Plaquenil, and so the jury's out right now against it. But, I do think that clinicians did have a positive experience with it. It is certainly not recommended currently.
All right. And I think just a message, if you have patients out there who are taking hydroxychloroquine, because they are, right? So let's just be realistic on it. Dr. Meller, what do you tell them to do to make sure they're safe?
I tell them exactly what I feel. I tell them that I would not prescribe it. If they want to take it, they may take it. It's okay. It's okay with me. I usually have to check the cardiogram to make sure that the QT is all right. I tell them to get an electrocardiogram just in case the QT gets long, just not to take any risk with the heart at that point. But I tell them I don't believe in it, and I say exactly what Larry says, that lots of people believe in the drug, and I don't know if they want to take it, it's fine with me, but it's not something I would prescribe.
I think it's a very smart way you're saying it, which is just because people are saying it's so dangerous, and it's really hard to believe. I certainly don't prescribe Plaquenil to anyone, and I think that, in my personal opinion, I think most people get better with COVID, and most people took Plaquenil at the beginning, so there's an association that Plaquenil gets you better. And maybe Larry's right, that association was symptomatology, but I certainly don't think it's dangerous as we seem to make it out. But certainly, again, we have to believe in science, and science did studies and it doesn't seem to show it, so we cannot recommend it. I'm just curious on the panel along the same lines. I mean, certainly antibiotics comes up all the time. People are being given macrolides, they're giving azithromycin, they're giving Levaquin. Should these patients all be on antibiotics?
Right.
I'll let you start.
I'm sorry. So I think that interestingly, macrolides have had anti-inflammatory properties, and we've used them in other situations. So that may be why, they have some theoretical benefit, but there's really no good evidence for them. And macrolides can actually also have an effect on the heart and the QT. So I think they're actually not indicated. Most of the patients who have COVID early on do not have a superinfection with the bacteria. So COVID is a viral infection. When we use macrolides in people with chronic lung disease, we're using it as either an anti-inflammatory medicine in some instances, or to prevent recurrent infections. And so it's just muddying the waters, what I would say. It can also give you a stomach ache. Many of these medicines actually cause the stomach to contract. So, COVID can affect the GI tract, and it can just make your stomach worse. So I don't recommend azithromycin or Biaxin.
Dr. Bander, I wanted to add that, you and I have probably at this point seen hundreds of patients in the hospital. And I would venture to guess that more than half of them, and probably more than that actually, probably got Zithromax prescribed to them in the outpatient setting prior to coming into the hospital. And so while that's not any sort of controlled study, I think that we have anecdotal evidence between all the people here that have taken care of patients, of plenty of people who took Zithromax in the outpatient setting and still ended up in the hospital with the same issue. So I 100% concur with Dr. DiFabrizio that I don't think there's a role for it unless once they're in the hospital, we think there's some sort of coexisting infection on top of the COVID.
Okay, I'm just gonna read some more of these questions that have come in. 37-year-old, positive rapid swab, chills. People want to know what they should take. So we're saying basically here is, if you're young and you're healthy, we're saying steroids if your D-dimer is positive, steroids if your oxygen is dropping. All our therapies are dependent on your oxygenation. What else can we have these patients take if they don't qualify to come into the hospital?
I mean, Tylenol and chicken soup and Gatorade is probably just as good and safe.
All right. Dr. Meller?
I don't give anything to the patients. The 80% of the patients really have like a minor, you understand me, they may not feel well, they are not short of breath, they don't have a cough, they just feel pains all over, headaches, stuff like that. And I usually tell them take some Tylenol just for discomfort of the muscle discomfort, but I don't give them anything else. And I tell them keep well hydrated if they're not having, but nothing else really.
Right. I think psychologically
If they get sick at that point, if the fever goes up, I think we all do relatively the same at that point. It depends on how sick they get. I may send them to the hospital.
Right.
Yeah, I think we're all along the same lines. I'm trying to tease out that borderline between who can be treated at home before they reach that marker where we're telling them to come in. And it seems to be a really thin line because we don't want to miss those patients. And right now we still have capacity to treat it. So no one's saying, hey, the hospital's overwhelmed, stay home and do your best. We're still saying come in. So, again, I still recommend vitamin D, vitamin C. I think zinc is a great thing to take. There's no harm. 225 tablets might cause some also, GI discomfort or skin issues, but also things that you could take at home that both help shorten the course or prevent. But there is nothing to take. You're right if we're sick. I got a question for Dr. Lubell about
may I just say something about the?
Sure.
So there's clear evidence that those people who are vitamin D deficient patients do worse. They may be more susceptible. It's not clear that supplementing the vitamin D will reverse that, but vitamin D is an important marker of susceptibility, and I generally recommend the vitamin D for everybody.
So a question for Dr. Lubell. How do you treat the COVID positive people on delivery? How did that change?
So it really depends on symptomatology and severity of disease. Most patients coming in would be asymptomatic or would have mild illness. So generally speaking, in those patients can be observed at home. If, however, they're starting to have respiratory issues, we do want them to come onto the labor floor. Those patients are isolated from the rest of the department. Oftentimes, those patients will be placed on a fetal monitor, depending on their gestational age. If they're beyond 24 weeks, we do want to know the fetal status. The fetus is dependent on the proper oxygenation of the mother. So it basically comes down to respiratory status. If the respiratory status is decompensating, then the thought is delivery may help. There's actually no data to support that, but it's more the theory of evacuating the uterus and allowing for the improving the mechanics of breathing. Because of the gravid uterus, there's a lot more pressure up on the diaphragm. It could decrease the venous return. You can also have a decrease in functional capacity. So delivery under extreme circumstances of severe illness may help. And then the other question is whether these patients can labor. Obviously, under acute settings, the answer is they usually don't labor, and that's why the cesarean section rates are higher. Whether it actually, there's no data to say that it changes outcomes, but that's been the process.
From a practical perspective, patients who are most of these patients are either low symptomatic or asymptomatic positives. Family visitation, father at delivery, what's the
right? So I'll just give you a rundown of what the process is. Any patient coming into labor and delivery does get swabbed automatically, them and their partner. Now the hospital's allowing partners to come in. They can also have a doula. That's the only other partner who's allowed in. Everybody gets swabbed. It has to be real-time PCR. It can't be a rapid swab. Oftentimes, especially with our patients, they may deliver before the results come in. Those patients are considered under investigation, and the full PPE is used until the results do come back. So essentially, they have to remain in the labor room. The husbands need to stay in the labor room. Everybody has to wear masks. Anybody entering the labor room needs to have full PPE until results are back.
What about the infants themselves when they're born?
Right. So an infant born to a positive mother is automatically considered a PUI, a patient under investigation. Those infants do room with the mother. There's no data to show that there's a decrease in transmission if the baby is outside or within the room. And there is also data that supports in-room bonding. The babies do better. The recommendations are for a COVID positive mother who is breastfeeding to use a mask, gloves, and just to clean the breast prior to breastfeeding, but there's no contraindication to breastfeeding. In fact, it's encouraged.
So it doesn't really change anything, and we're not seeing sick infants this time?
No, and that's the good news. Most infants born from COVID positive mothers, they were not any worse off than children who were born to negative mothers. The risks were more associated with preterm delivery more than anything else. Most of them do fairly well. Those that were COVID positive rarely needed any respiratory support. So they seem to do pretty well.
So that's good news, at least one area we don't need to really worry about. I just want to switch topics back to treatments for a minute, then I'm going to move back into testing for the last segment. I think we're finishing at 9:20, 9:30 we'll finish. 9:20 we'll finish, and we'll leave some more questions, but keep the questions coming. I'm getting a whole ton now towards the end now. Can't get to all of them, but we're seeing a ton of patients now who got plasma, but we also now have monoclonal antibodies out there. And the questions that I'm getting is, who should get monoclonal antibodies? I'll just say briefly, it's a great option for people who are sick in that risk factor group, who, like, recently President Trump received what are called monoclonal antibodies. Basically, it's plasma that's they take one of these antibodies and they make copies of it, and they give you an infusion of it, and you get it as an outpatient. So people who are high risk can be enrolled in a trial to get it. Unlike President Trump, you don't get to get it; you have to be chosen. So if you have COVID in the last 7 days, you can, or diagnosed in the last if you're diagnosed with COVID for the last 7 days, you would be a candidate to be screened for this trial where they would give you these antibodies as an outpatient, and you would not need to be admitted to the hospital. So right now, the role of monoclonal antibodies, as far as I'm concerned, is for patients pre-hospital or who get to the hospital and are not hypoxic, those patients whose oxygen are still above 94%. So those are the patients that should get monoclonals. But as an outpatient, all these people that we talked about, your diabetics, your risk factors, hopefully that will be the treatment of choice for them if it works. So pre-hospital is where you should be getting monoclonals. If you're already sick enough to be in the hospital and you make it there, you should get plasma, because there's there's really no randomization. You're not going to get a placebo treatment. So I do think I really encourage that. I would like to send out more information after the call about that. I want to get to some of the other questions here about testing positive a second time. So we spoke extensively on the last call about antibody testing. I want to ask the panel, can we get COVID again? What's your opinion, Dr. Meller?
I think that what I have learned is that you probably cannot get it again. There are those few cases that there have been a mutation. It's a different virus, and there's 3 cases or 4 cases. But according to what I understand, you can be tested, be positive, but it's for a fragment of the virus, which is not infectious anymore. You understand?
That was in the 8 weeks post-infection, right? But the question is, if you tested positive 8 weeks in Passover time, and then you cleared it, and now you're testing, can you test positive again, or is that a live virus?
That's what I'm saying. The suspicion is that that's not an alive virus. It's a particle of the virus, not infectious. But that's the speculation. I mean, I don't know if there has been any more studies about it, or any more cases of that.
Larry?
So I agree. I mean, the vast majority of patients can be shedding viral fragments for months and months. We've had people who we've cared for that have positive antibodies and are well, but still have, a positive PCR. And it's a conundrum of what, getting them back to work and things like that. But there is a case report of a gentleman who is Chinese, got COVID in China, got over it, was medically sick at the time he was in China. Then months later went to Europe, then came back home, and he tested positive for PCR. And that person was investigated. He had no symptoms, so he had an infection, but actually no illness, and it was a different virus. So that person actually probably had immunity to the infection, so the immune system kind of like fought it, but they tested positive. So, it's going to be an interesting question as we move forward about what is the implication of being reinfected. Yeah. So I think that many of us, those of us who did get sick, will have antibodies, and that will form some type of protection. there are some people which will have cellular immune responses. So there are things that we can't measure so well. And, hopefully, having been sick previously will, at least if you get it again, you may be able to fight it off better.
So anyone on this panel, right, and I asked this last time too, has anyone seen a confirmed reinfection? And we're seeing a lot of patients and hearing a lot of patients.
No.
Personally, I have not.
Right.
I haven't. Jeff, can I chime in on your last question? I think that although I have not seen a reinfection, I think our audience knows that I am involved with some of the testing we're doing, and we have seen patients whose antibodies have fallen. Now, I have not specifically seen patients that have had their antibodies fall down to zero, then develop an infection. But I think this is the key question for what comes next. And I don't think anyone on this panel has the answer to that, but it is concerning to me that we're seeing some patients maintain their antibody levels or fall a little bit. And we're seeing some patients who've gone from high antibody levels to zero.
Yeah, I think that's the key. When we had this call on Shavuos time, we were pretty convinced that antibodies were going to be sort of your passport to the future. And now we're not so sure. We're seeing them drop, but we have not seen reinfections. And again, when I think what tells that, and I said this last time too, was we're seeing tons of people who are around positive people who were infected previously, but they're not coming in. So there is still immunity there. What we don't know is because we're seeing antibodies drop, will that last? And we said last time, we just don't know. People don't develop long-term permanent immunity to these similar viruses in the past. So we're still hoping that right now we're good, but clearly we're not. We've already gotten rid of the whole idea of herd immunity last time because clearly our herd is not immune. We are, as a community, still getting sick. We're not protecting each other by having had the virus in the past. And we don't know what the antibodies mean. I think right now they are protective, but we don't know if they're going to last. Anyone have any other thoughts on that?
Yeah, Jeff, can I add one more thing?
Sure.
I think a common thought that I heard in a lot of the communities after the first wave was, I'm on Hatzalah, or I'm a midwife and I was around this and this many number of patients with COVID, and I never got it. So I think I'm good. I think I'm safe, because if I could take care of 50 people in their houses and not get it, I'm going to be good. And I think I'm starting to see now a whole bunch of those people who thought they had some sort of silent or immunity that protected them the first time around. They are getting it this time. And so it's truly not understood. But I would like the audience to realize that just because you didn't get it the first time doesn't mean you have some sort of magic protection this time around from getting it. And the proper precautions should be taken.
So I'm going to get to the last section about testing, and then we're going to finish. But I do think that that's a really important point, was that a lot of people thought they had COVID back in Pesach time when they had the flu or they had the cold or another virus, and they're protected. Those are the people we're seeing now. We're seeing people. No one we've seen in the hospital said I had a confirmed PCR back in Pesach time. Nobody. So it's clear that these are the people who were not infected the first time. So that leads us to the last round. I mean, and I'll start with you, Larry. Should everyone get tested? Should everyone get antibody tested? Should everyone get PCR tested?
I think everybody should get antibody tested. Absolutely. I mean, I think we need to know who's had it before and who doesn't. I think if you have any symptoms that are suggestive of a viral illness, it's appropriate to get tested. The flu season is coming up. Everybody should get a flu shot, fully every year. 30 million Americans get the flu. 12 to 60,000 people die of influenza a year. So, and the flu symptoms are the same as COVID symptoms. And quite honestly, everybody's going to go crazy, because if they have the flu, they're going to be worried they have COVID. And, the flu, particularly, we discussed about viral infections in pregnancy. The H1N1 was very devastating to pregnant women too. So, the risk groups are the same. They need to be immunized. I think I would love to see a day when we are able to test people in the community with either a rapid test. If there's a point of care testing, we should be getting it and we should be doing it. Because if we can find patients who are either antibody positive, well, they know they're protected. If they're antigen positive or PCR positive, and it's an easy test to do, then you know that you're negative, your bubble, your inner circle of people are safe. And then you could stick with that bubble of people. They're doing that in the baseball right now. So I think that's a good concept. There are schools like University of Southern California at San Diego where they have a research project where they're planning to test their students every week to at least every month, and to make sure that if they find cases, they can isolate these outbreaks right away. Many people have very little symptoms and they can be, passing it along. 40% of patients with COVID have minimal to no symptoms.
Jose?
I agree. I cannot add anything. I agree. I think that we should do enormously more testing. And I have the experience with somebody in college who actually got tested once a week, every week. And when they got somebody that had the virus, they put everybody else in quarantine, and that person was isolated in a completely different place. So, and not hospitalized because he was not sick.
Yeah. So it sounds like antibody testing really is key. It's important. We don't know how long it lasts, but it is important. The numbers, we're getting a lot of questions about the numbers. There's different types of antibody testing. The point of care testing, they're not as accurate or reliable, but they're still pretty good. And I would say that that's the test that's most easily available. The titer tests, they're just more accurate and they tell you your level of antibodies. It's really most useful to let you know if you have high load antibodies, and you can donate for convalescent plasma or hyperimmunoglobulin, which is very helpful. We're collecting it at Mount Sinai. New York Blood Center is collecting as well. If you have antibodies and you have high titers, you should definitely be donating. Mount Sinai has a center that's open 6 days a week. You can just walk in. We can send you the information, and we'd actually really appreciate that. It's been very helpful for us. But you don't need to know your titers. You just need to know if you're positive or negative. And I think we'll have to find out how often you have to check it. So let's see if there's any other questions that we can get to before our time is up. Someone said so if you do have a reinfection, people are telling me they have a reinfection, you have to send us a titer. So you have to send us a positive swab from before, in the first wave, and the positive swab in the second wave. That's the only way we'll know for sure if it is. Even the antibodies are not going to be enough to prove it. And so one of the things that just came up also is a question about, we are seeing a jump in some people's titers months later, and that's probably because they were exposed again to COVID. So if you had an antibody titer of 2880 and it went down to 320 a few months ago, and then you came in contact with someone, your body probably fights off the COVID. The antibodies don't prevent you from having the COVID go in your body. They don't. They do is they'll help you fight off the virus. So you probably can get what we'd say reinfected, meaning the virus can go in you, but your body fights it off. When you have immunity to the flu, you breathe in the flu and you fight it off. You just don't grow it, but your body will respond to it. So seeing a jump in titers means you were probably exposed to COVID, and we're going to see a lot of those people. So if you had low titers before and you were exposed to someone, retest now, you might be a donor for plasma. So just to get to the last part, and then I'm going to end, PCR testing, there's implications for it now. So the point of PCR testing to me is to know that you should quarantine and you should stay away from people. Larry, any closing thoughts on that?
I mean, absolutely. I think if you have any symptoms, or if you've been in contact with somebody who's actively ill, and this has happened in families where, as I said, I have one family that I've taken care of for years, and this very scrupulous son got it, and then I said, "Oh my God, they're all going to have it," and they did. So I think if you're feeling sick and you're positive, then your whole bubble needs to be tested. Everybody that's around you, your own family network, it's important to protect each other. If you love each other, making sure you're doing the proper isolation techniques and masking and family testing is very, very important.
Yeah, and we stayed away from this tonight because de Blasio and the governor really hit hard because looking at the positive testing rates, and we're not going to really get on this tonight, but again, as a community, the only way we're going to stop this is by stopping the spread of it. As you can see, we did get rid of COVID, after basically, before the summer. It was gone. We had very few positive tests. And that's because nobody we were interacting with was bringing it in. Once it's inside of our community, we're a very social community. So it's easy to ping pong around. Once it gets into one wedding and people from one community go, it just bounces around. So until we are able to isolate those cases that have it, stop them from spreading it, it's going to continue. So we need to really get a hold of that. And what's your, Josh, what is your biggest advice to people to stop the spread?
I think the most important thing, irrespective of all the politics around it right now, is social distancing and wearing masks and not cramming on top of each other in small spaces without wearing masks. I think that's the shortest and simplest way I can put it for trying to prevent the spread within the community.
Dr. Meller?
This mask and distance by far the most important, but also not to get into close spaces with crowds, let's say. And people tell me, can I go and visit my grandchildren? I said, no. If you want to meet outside and keep the distance. Meetings outside are all right, but even then keeping the distance, not next to each other.
How long do people need to quarantine for?
Usually we say the 10 to 14 days. You're
Larry,
talking somebody who was in contact with somebody.
Yeah, I
If
think
it was
that's what
not
the
a
CDC
contact. If it was not a contact, 7 days should be enough.
Yeah.
You understand me? If you yourself, well, you're in contact with all the time, but I'm talking somebody tells me, listen, I'm healthy, I want to go and visit somebody. I would say 7 days, you don't get into close contact with the other person.
7 days.
7 days, right?
If you're
7
positive,
days it's not a magic number, by the way. In theory, Fauci says 14 days is the normal thing. But if you really haven't been in contact with anybody, but you want to keep the other people safe, that you're going to go and visit somebody in another state, let's say, 7 days is what we say you should not get close to them.
Jeff, can I add something?
yep.
I think it's really important, as a shul goer myself, if you test positive, even if you feel fine, please don't go to shul. Please don't go into a store. I think it's really important to quarantine and stay away from people, even if you are feeling fine, if you've tested positive, to stop the spread of this virus and this disease.
And I agree with that wholeheartedly. That is the only thing that we can do. That is the most important thing, is stay away from people and wear a mask.
Dr. Bender, I think
Yes.
that we need to reinforce, there's some confusion among the public, 24 hours without fever and the 10 days, and then it's 24 hours without symptoms, which is, I'm not sure where that came from, but if you can reinforce, what is the 24-hour period without fever versus the 7 to 10 days versus 24 hours without symptoms for a patient who tested positive?
Dr. Larry, you want to take that?
Yeah, so I have to review the exact guideline, but there's a time period. If somebody's been, let's say day one, you get a positive test, and you have to be quarantined for a minimum of 10 days, or 3 days after your last fever. So if you're having fevers for 10 days, you're not out of jail yet. You have to stay quarantined if you have ongoing fever. So you have to have at least 3 days after your last fever, or more than 14 days. I mean, there are probably some patients that we're seeing in the hospital that are very, very sick that can have fevers for 3 weeks. And if you're still febrile, unless you have COVID antibodies, you still can give it to people. So it's a 10-day minimum, but you have to be without fever for at least 3 days and the 10 days.
All right, so let's reinforce that.
10 days, you have a longer isolation period. Now, it is generally true if you're exposed to somebody, almost no patients get COVID more than 14 days after an exposure. So there's a difference between being an exposed case or somebody who's been actively sick.
Okay. So we got that 10 days from when you test positive, or get sick, if you've cleared, if you're feeling fine, and 3 days minimum from when you clear, from when your fever and you feeling better, correct?
Right.
So let's just make sure everyone knows that. And then if you took steroids, it might be longer than that. So that's one of the things we don't know yet. So
Yeah, I think these are best guesses. Many recommendations are not made with absolute knowledge, but there is at least a paper, it's a very well done paper about exposure. That 14, you're very unlikely to get sick if you've been exposed to somebody, 14 days ago and you didn't have any symptoms.
and if you test negative, does that mean anything? I know you can have.
Well, the problem is that
Positives.
if I do, I'm working in the hospital, and if I have a COVID test on Friday, I may be negative on Friday, and I may get sick on Sunday. So, that's a snapshot in time. So the COVID testing is helpful the moment that you actually, get the test, that no virus is detectable. But it's not a false sense of security. You still need to do the things to protect you and your family. Because you can get sick a couple of days later after you have your COVID test, and then you may start spreading the virus.
Each of these topics need their own 1 hour show. So we were trying to just cover each of these topics very fast. I think right now the biggest important thing we covered was to review was, come in, if you're going to come in early, test yourself by looking at your oxygen. We talked about the therapies that we have. We have good, efficient therapies. And quarantine, wear a mask. I mean, I think that's the theme for tonight. So I want to thank everyone for being on the panel. Dr. Meller, Dr. DiFabrizio, Dr. Lubell, thank you, because we haven't talked about pregnancy and delivery before. And so if there are other questions, you can email us, and we'll see when we have time for more questions.
Dr. Vander, you did very well there.
Thank you for having us.
Thank you.
Thank you.
Thank you.
Yeah.
Bye-bye.
Good night.
Good night.
Bye.